Hello, and welcome to the fifth episode of our Innovations in Dermatology podcast. This podcast is entitled Cutaneous Malignancies 101. My name is Vishal Patel. I am a dermatologist and Mohs surgeon. I serve as the Director of Cutaneous Oncology at the GW Cancer Center in Washington, D.C. And joining me today is an esteemed colleague and close friend, Dr. David Miller. Dr. Miller is a medical oncologist and dermatologist, dual certified in both, at the Massachusetts General Cancer Center in Boston, Massachusetts. Welcome, Dr. Miller.
It's a real pleasure to be here, Dr. Patel.
Well, today we're going to be discussing a topic within a broad topic. Cutaneous malignancies is quite a broad topic. So we've honed in on focusing in on keratinocyte carcinomas and specifically some new developments that have occurred in the last several months that is really exciting us here today. In particular, we're going to discuss gene expression profiling, or GEP for short, in cutaneous squamous cell carcinoma, a new staging system in basal cell carcinoma, as well as some advances in the staging systems of cutaneous squamous cell carcinoma. We're going to then move to therapeutics and talk about very ultra low risk or precancerous disease management with actinic keratoses, therapeutic developments, as well as new developments in advanced keratinocyte carcinomas. So let's start it off here today. First, discussing what's been some new recent developments in risk stratification in cutaneous squamous cell carcinoma management. In particular, a new gene expression profile test that has come out on the market for high-risk cutaneous squamous cell carcinoma. So, Dr. Miller, can you start off by explaining what gene expression profiling, or GEP, is, and how are you using GEP to risk stratify your tumors in your patients, and how do you incorporate it into your practice?
Well, that's a great series of questions, Dr. Patel. Gene expression profiling is certainly an exciting tool that has been used by oncologic practitioners for some time now. The concept that patients could be risk stratified by differential gene expression patterns in the tumor microenvironment was popularized over the last decade in breast cancer. The 10,000 patient NCI-sponsored study TAILORx provided data that the choice of post-operative therapy for patients with hormone receptor positive, negative breast cancer could be influenced by gene expression profiling. Now, while we don't have a 10,000 patient study behind the use of gene expression profiling in cutaneous squamous cell carcinoma, we do have an interesting proof of concept data set that was recently published in the Journal of the American Academy of Dermatology. In this study, 586 localized high-risk cutaneous SCCs were used to develop and then validate a 40 gene expression profile test to predict metastatic risk. These investigators found that high-risk tumors could be stratified into a lower risk group with a 9% 3-year event rate of regional or distant metastasis, a high-risk group that had a 20% 3-year event rate, and a highest risk group that had a 60% event rate at 3 years. These data are intriguing, and I am optimistic that gene expression profiling will have an important role in the management of high-risk cutaneous squamous cell carcinoma. Exactly how we incorporate GEP into our day-to-day practice remains a little uncertain. Additional prospective studies that test clinically relevant hypotheses, like TAILORx, are certainly needed. However, due to the limited abilities of our current staging systems to precisely risk stratify patients with high-risk disease, gene expression profiling can provide us with additional data to help guide our workup and management.
That's really exciting. I'm equally intrigued and excited by these new developments, but I think you noted this is for cutaneous squamous cell carcinoma alone, and there is no gene expression profiling in basal cell carcinoma. But there is a new staging system from what I understand. Can you tell us a little bit about that new staging system? How is it different from the AJCC staging system, and how are you using it in clinical practice?
Well, Dr. Patel, the AJCC and Brigham and Women's staging system for basal cell carcinoma differ in a few important ways. First off, the AJCC staging for basal cell carcinoma is the same exact criteria and format as for cutaneous squamous cell carcinoma. AJCC risk stratifies lesions into 4 levels based on size and certain pathologic characteristics such as depth of invasion and perineural involvement. In contrast, the new Brigham and Women's BCC staging has only 2 levels, T1 and T2. T1 lesions are those tumors that are either less than 2 centimeters, or greater than or equal to 2 centimeters with 0 or 1 risk factor. We'll describe those risk factors in just a moment. T2 tumors are those with a diameter greater than or equal to 2 centimeters with 2 or 3 risk factors. The risk factors that prognosticated a significant risk of metastasis or death included what we refer to as the 2Ds and location. That's clinical diameter greater than or equal to 4 centimeters, depth beyond fat, and location on the head and neck. Now, these significant covariates were identified in an analysis of 596 tumors, 248 of which were greater than or equal to 2 centimeters, while the other 248 were used as controls. They were randomly selected, and they were all less than 2 centimeters in maximum diameter. The 2 centimeter size was chosen because the risk of regional or distant metastasis has previously been shown to be less than 5%. Although subsequent validation in a separate data set would be ideal, having a fairly straightforward way of dichotomizing risk for patients with an extremely common malignancy has the potential to be quite useful clinically. For example, the aforementioned risk factors could be used to appropriately select basal cell tumors that would benefit from radiologic imaging, close follow-up, or even potentially adjuvant therapy.
Well, that's really interesting to hear. For so many years, we've been focusing on cutaneous squamous cell carcinoma and discussing the 2 staging systems. So it's exciting to see that basal cell has entered into that foray. But can you tell us about cutaneous squamous cell carcinoma and kind of round out that discussion? Tell us how you're using those 2 systems, and have there been any improvements on that front?
Great question. So, I do use both staging systems for all my high-risk cutaneous squamous cell patients. Now, the AJCC is truly the lingua franca for staging in oncology, and I need to use it to communicate to my colleagues in surgical oncology, radiation oncology, and medical oncology, as for many of them, it is the only staging system they have familiarity with. As a result, it is more common to find inclusion and exclusion in clinical trials that incorporate AJCC staging. But with that said, I also use the Brigham and Women's staging system, as recent data has demonstrated superior discrimination, distinctiveness, and positive predictive value with the Brigham and Women's staging system as compared to the AJCC staging system. In particular, the AJCC staging system has limitations with discriminating outcomes in patients with T2 and T3 lesions. That is because there are still a subset of T2 lesions that have unfavorable outcomes, and many T3 lesions have favorable outcomes. Now, due to the heterogeneity in T3 lesions, a recent refinement has been proposed by a group in Salamanca, Spain. They published a series of articles in the JAD over the last year that describe a subcategorization of T3 lesions into essentially a lower risk T3 and a higher risk T3 subgroup. In an analysis of 196 tumors, they found that those lesions that were greater than 4 centimeters in largest diameter, but did not invade beyond fat, nor had any perineural invasion, fared better than those lesions that had invaded beyond fat or demonstrated perineural invasion. Not surprisingly, they found that lesions that had both invasion beyond fat and perineural invasion had the highest rates of disease-specific poor outcomes. Unfortunately, what we know is that both the AJCC, even with the Salamanca refinement, and the Brigham and Women's staging systems both have suboptimal accuracy and positive predictive value. This underscores the need for improved methodologies to risk stratify patients to better guide our management.
Well, thank you, Dr. Miller. That's a very thorough discussion of staging, and we've just discussed that risk stratification approach for high-risk tumors. But what about the other end of the spectrum, the low risk or the ultra low risk, or even precancerous lesions? Have there been any developments on that front from a therapeutic standpoint?
Yes, that's correct. There was a recent addition to the therapeutic armamentarium for actinic keratosis, tirbanibulin. It was approved on December 14th, 2020, based on data from 2 double-blind, vehicle-controlled clinical trials of 702 adult subjects with actinic keratosis on the face or scalp. 44% of subjects in study 1 and 54% of subjects in study 2 met the primary endpoint of complete clearance, compared with just 5% and 13% of subjects that received the vehicle. The most common adverse reaction, i.e. those with an incidence of greater than or equal to 2%, or local skin reactions, application site pruritus, and application site pain. Tivanabulin joins an assortment of topical treatments for actinic keratoses on the face and scalp, including fluorouracil, diclofenac, imiquimod, and inguinal mebutate. As you know, these treatment durations range from 3 days to 4 months. Therefore, tibanabulin's 5-day course of once daily treatment is on the more convenient end of the therapeutic options that we have for actinic keratoses.
Very exciting to see the new therapeutic options on the precancerous side. Let's come back to the aggressive disease we were talking about earlier on. What's new for advanced keratinocyte carcinomas on this front, Dr. Miller?
Well, indeed, there have been some recent developments in regards to advanced keratinocyte carcinoma. In fact, we have new approvals for both advanced SCC and BCC. On February 9th, 2021, the FDA approved cemiplimab RWLC for locally advanced basal cell carcinoma or metastatic BCC previously treated with a hedgehog pathway inhibitor, or for which a hedgehog pathway inhibitor is not appropriate. This approval was based on a study of 84 patients with locally advanced disease and 28 patients with metastatic BCC. The primary endpoint for this study was objective response rate. 29% of the patients in the locally advanced group and 21% in the metastatic cohort had an objective response. Now, importantly, 6% of the subjects in the locally advanced group had a complete response. The study demonstrates the proof of concept that immune checkpoint inhibitors can have meaningful activity in basal cell carcinoma. It is quite important to have additional therapeutic options for advanced BCC because while hedgehog inhibitors have good and important response rates, the majority of patients will acquire resistance and or will become intolerant to the adverse events. Now, we also have important updates for cutaneous squamous cell carcinoma. On July 1st of 2021, the FDA approved the supplemental biologics license application for pembrolizumab for a new indication. That is for the treatment of patients with locally advanced cutaneous SCC that is not curable by surgery or radiation. This approval was based on additional data from Keynote 629, which is a phase 2 study of pembrolizumab monotherapy for locally advanced or recurrent metastatic CSCC. Of note, this adds to the June 24th, 2020 approval for patients with recurrent or metastatic CSCC that is not curable by surgery or radiation. In Keynote 629, of the 54 patients with locally advanced disease given pembrolizumab, 27 or 50% had a RECIST criteria-defined response, with 33% of subjects having a partial response and 17% demonstrating a complete response. So pembrolizumab joins cemiplimab RWLC as the only 2 checkpoint inhibitors approved to treat locally advanced or metastatic CSCC. In regards to cemiplimab, we saw interim updated results from the Empower CSCC1 study at the European Association of Dermato-Oncology Congress this past spring. At that meeting, further follow-up data at approximately 43 months after the primary analysis was presented. These data demonstrate incremental improvements in duration of response with cemiplimab across all advanced CSCC study groups. Importantly, 2 additional patients treated with the currently approved dosage of 350 milligrams every 3 weeks achieved a complete response, bringing the CR rate up to nearly 20%, with an objective response of approximately 47%. Also important was the fact that no new safety signals were seen. Suffice it to say that immune checkpoint inhibitors remain the frontline therapy for the majority of patients with advanced CSCC and are becoming an important therapeutic option for advanced basal cell carcinoma.
Well, thank you, Dr. Miller, for providing us such a broad overview of the updates of keratinocyte carcinomas. It's really exciting to see such great developments on the whole range of presentations of disease here. I want to thank everybody for listening in and participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.